Question number 51. The clue given is 60-year-old female. 60-year-old male with AK, and this finding. What is the finding? C3 is low, C4 is borderline low. Ideally, it have to be 90 to 130 C3 milligram per deciliter. These are complement levels. What is the clue? C3 can be low in SLE, IRGN, any kind of immune complex glomerulonephritis. Whereas if you take this 60-year-old male where SLE is very, very rare, my patient presented with AK. In IgA, usually C3 remains normal. Here C3 is low. So the answer out of these two, IRGN. IRGN, previously called post-streptococcal glomerulonephritis, post-infectious glomerulonephritis. Now they have found along with infection it can occur. That is why it's called infection-related glomerulonephritis. So in the X-ray, you are seeing a central line which is placed on the left internal jugular vein. The question is, which vein is preferred for central line insertion and why? Ideally, a right internal jugular vein or internal jugular vein either of the side is valvulus, direct in connection with the heart, also easily accessible, even if there is any bleed, easily compressible because it is somewhat exposed compared to the other sides like subclavian, and the chances of infection is less compared to the femoral. In the femoral, the puerperal area is nearby or the perineal area is nearby. That is why the risk of infection is high. That is why IJV is preferred. What is the eGFR cutoff to stop dapagliflozin? Previously it was 30, currently it is 20. Even if the patient eGFR falls when the patient is on dapagliflozin, no need to stop because the dapagliflozin, as per the current guidelines, says it is cardioprotective. Even in CKD patient who was on dapagliflozin, eGFR is falling, better not to stop it. The cutoff, you can take it to initiate. Previously it was 30, now it is 20. In the future, probably it might be going for some kind of change, but as of 2025, you can take 20 as the cutoff. Name few indication of plasma. There are so many indications starting. You can divide that as heart related, spine related, kidney related. Give you example related to crime, Guillain-Barré syndrome, the most one, acute disseminated encephalomyelitis, NMDA receptor antibody encephalitis, and many more. In the kidney, you can say this antibody mediated rejection, exclusive transplant is excluded. You can take it for ANCA-associated vasculitis, TTP, cryoglobulinemia. There is one video regarding indication of plasmapheresis I made that you can go through, but most commonly, those who our student wrote Guillain-Barré syndrome, we gave full mark. Guillain-Barré syndrome, and one more you common clinical encounter situation is ANCA-associated vasculitis, TMA, and TTP. Okay. Another a simple understanding concept level question where patient is excreting 8-gram proteinuria but dipstick is negative. What is the diagnosis? Clear cut, it is a case of multiple myeloma because Benz-Jones protein dipstick detects only the albumin, whereas in multiple myeloma a large amount of Benz-Jones protein might be excreted, which is not detectable by dipstick, but 24-hour protein estimation can detect it. These kind of questions you might have got during your MD times, the high level of proteinuria and Benz-Jones protein positive they might have given. So here you might get this kind of question. And one more thing, whenever the proteinuria is very, very high, more than 8 gram, the differentials are membranous amyloidosis, and then any kind of monoclonal gammopathy associated kidney disease. These kind of values can be found in the 24-hour urinary report or urine ACR PCR report. but you have to correlate with the serum albumin, because whenever a patient is excreting this much protein in the urine, the albumin usually comes below less than 1.5. Suppose if the albumin is normal, what that indicates? This could be lab error. Okay. Herpes zoster prophylaxis to be given before which medication? The answer is bortezomib. See here, another question, bit conceptual. Creatinine is 2, patient underwent dialysis. Many a student took the value as 2 and started calculating the stage. In AKI, whenever a patient underwent dialysis, despite the value of creatinine, the stage goes to 3. If hyperkalemia, volume overload, whatever the stage, creatinine maybe, if the patient is taken for that particular scenario, the AKI stage goes to stage 3. A very famous MCQ. Some beginner level doubt will be there, sir. Creatinine to how come patient might be in volume overload? Again, I am telling, uremia, volume overload might be dissociated. Patient might be significantly volume overloaded, even though creatinine might be 2. Or in situation where AKI is worsening, where anuria is there, where we are taking the patient at a lower creatinine for dialysis. That also bring the patient automatically into AKI stage 3. So at least for this MCQ, answer is stage 3 as the patient underwent dialysis. And there is a video on AKI and dialysis which was made around 10 days back, especially for the final MD resident, when to decide for the need of dialysis in AKI patient. Don't go by the mnemonic, don't apply the blanket scenario in all the patient. You have to see the recoverability. That's why I was telling, because some student might be having doubt. Creatinine is 2, how come patient is for dialysis? For those who are having that doubt, you can go to that particular video, AKI and hemodialysis. That video link I will provide in the description. This is the erythropoietin. The question goes like that. Patient doesn't want to have pain because of the erythropoietin injection. The patient is asking for any other oral formulation. So the question is, what is the oral formulation drug for anemia recently being used in CKD? These are HIF inhibitor, desidustat. And commonly we are using in OPD, the brand name is Oxemia, 50 milligram or 100 milligram tablet, alternate day or twice weekly, which is the oral formulation in place of erythropoietin in CKD, HIF inhibitor. Indrenone, this is aldosterone receptor blockers. Where it is being used, it is used in CKD, prevent its rapid progression. CAD, for cardiac benefits, it has BP reduction properties. Okay. The last question, write down the Kraft-Gold formula. This you might have studied in your MD first year. Probably by now, many of the students might have forgot. The formula goes like this: 140 minus age into body weight by 72 into creatinine. Nowadays, we are using MDRD formula or CKD EPA formula. Despite that, you should know, even with the calculator, you can easily calculate this. So this completes the 60 questions from the quiz. And there was one tiebreaker question also. What was the contrast that was being used for MRIs? Gadopentate, DCT. Many of you wrote gadolinium. It is not. You have to write the specific step. Just gadopentate. For CCT, yes, iodine-based contrast is used. But what is that iodine-based? It is iohexol. So this completes the quiz. Question and the answer discussion. Congrats and best wishes to the students who topped the quiz.